Hello, medics. Now, today we are going to check on the newborn physical examination. We're going to check on the newborn physical examination. And just a quick one before any of you grows to this state where now you call yourself adult, maybe a parent. Once just a small centimeter, few centimeter long, maybe 50 centimeter. That was the moment that you were introduced to the world from the intrauterine environment. So we need to know the exact parameters or the criteria that help us to distinguish this is a normal newborn, this is abnormal newborn. When you talk about abnormal or abnormality in newborn, those are just failed demarcation or pathological complication that the child can be born with. Remember, after 9 months of gestation, the child has been spending his or her entire life in intrauterine, inside amniotic fluid, the sac itself. And now the child is out. So we have to know as medics, we have to know whether this child is supposed to be referred to NBU for admission, whether this child requires some immediate intervention to enhance the life, like to support the living livelihood of the physiological mechanism. Now, the normal findings. Let's classify first in general appearance. Let's general appearance. What do we regard to as the normal findings? So normal findings: active, alert, responsive to stimuli. That's one. Pink skin with good peripheral perfusion, flex posture of the upper and lower limbs. So active, alert, and responsive to stimuli. Remember, in a newborn, in small child, we normally use a scale of measuring consciousness, which is called the AVPU. The child responding to, the child alert, that is A, responding to voice, any pain, or the child unconscious. So it's either alert, responding to pain, responding to voice, or unconscious. So if the child is born, you can just realize the child is very active, jumpy, tries to kicks, okay? Yeah, and even cries. We talk about the activeness. Or maybe inactive when the child now is just sleeping, closed his eyes or her eyes, and then that is now the muscles are just weak, that is now inactive, okay? So the child must be alert in a way that the eye contact, you can realize if the child looks at you, the eye contact is just that. And anything stimuli, like sometimes we do slap at the plantar of the limb, check on if the child responds. Most of them will cry, okay? So the stimuli, we normally get to see if they can respond to pain. So then we also assess generally on the skin color. The pink skin with good peripheral perfusion is also an indication of normal findings, because we know we can have a blue skin sometimes. The blue skins just indicate what we refer to as a nosed baby. So that is to mean circulation has been severely impacted, and circulation, that is to mean maybe there is respiratory condition, respiratory distress, or complication anomalies such from congenital conditions like panted ductus arteriosus. All those one can give us blue baby, okay? So pink skin with good peripheral perfusion. And how do we note the peripheral perfusion to be good? We can pinch on the nails and see if the return, the peripheral return, the return of blood from the region is quick, and then you get to know there's a good peripheral perfusion. And some we can just denote the entire pinkness, demarcate a good circulation, okay? We also check on the posture of the upper and lower limb. Are they flexed? They're supposed to be flexed, okay? If they are straight, that's a questionable thing. If they are extended, it's a question thing. So they're supposed to be flexed. Then good muscle tones, we try moving the limbs and get to see if the baby is opposing to the energy that you engage with the limbs. So the good muscle tone, we can grade them from 1 to 5 basically. We have the least where the baby cannot even, you are the one who's just controlling the limb while you're trying to move them without the baby's interference, okay? Check on the spontaneous movement, symmetrical limb activity, strong spontaneous cry. The baby must cry, and immediately after birth, that is one thing that we normally we are concerned with, because if there is no cry, it may signify several things. One can be blockage on the airway. Two, we can be having acute respiratory distress. Okay, and three, many other complications can as well come from failure to cry. You can even the baby can be dead. You don't know. Okay, so normal level of conscience is also checked. Uncomfortable breathing without signs of distress also being checked. You can count the respiratory. You can use vital monitors to check on the I mean, on the vital signs. Okay, so that is that. Now let's check on the abnormal finding. Those were normal findings. Lethargy. These are reduced activity, weak cry, poor responsiveness. This may indicate things to do with sepsis. Remember neonatal sepsis. Okay, we have the earlier duration, the late duration neonatal sepsis. So hypoxia as well. The baby can be having deficit of oxygen supply. Also hypoglycemia, to mean that the baby might be not well with the sugars. The sugars might be low, so there is lack of energy. So we normally do random blood sugar test, check on the oxygen oximetry to check on the oxygen concentration. We also do some lab works like phlebogram to rule out sepsis, that is in case the child is lethargic. Hypotonia, floppy muscles with poor resistance to movement may suggest neurological or metabolic disorders. Hypotonia, we have hypertonia and we have hypotonia. We talk about hypotonic, the muscles are very floppy. There is poor resistance. This one now the muscle tone is as low as one, okay? So maybe neurological disorder or metabolic disorder. Neurological in a way that maybe some nerves are interferes with. So sometimes during the delivery process, we normally get to some what we call the birth injuries, okay, which can interfere with some given group of nerves like the branchial nerves. So with that, you'll get the floppy muscles with the poor resistance can be. Now in hypertonia, there is that increased muscle stiffness. It may indicate neurological injury or cerebral irritation. We talk about cyanosis. Cyanosis is just the bluish discoloration of lips, tongue, skin due to inadequate oxygenation. I know with the detailed knowledge of cyanosis, talk about the central cyanosis and the peripheral cyanosis. Okay. Talk about the pallor, pale skin appearance. These may indicate anemia, shock, or poor perfusion. Okay, anemia that deficit uh, in blood, so maybe it can be hemoglobin. Okay, so hemoglobin will indicate when you do full hemogram, we check on the HBs. We normally don't expect them to fall below 10. Okay, anything below 10 we classify as anemia. So can also be due to shock, hypovolemic shock, where now maybe we have internal bleeding, okay, or poor perfusion at large. So pallor, the paleness of skin, especially seen in the palm of the baby, okay, and generally the skin and mucosal surfaces. So even on the sclera is also possible. You can note the pallor. Cyanosis, you check them on the lips, tongue, that is it is central. Skin and the peripheral surface, that is with peripheral cyanosis, okay? That is that. So jaundice also come, that's abnormality. That's just the yellow discoloration of skin and sclera caused by elevated bilirubin. So we normally do bilirubin. We work out lab. We have some lab works to rule in if jaundice is secondary to. We know we have physiological jaundice. We have pathological jaundice. You can do direct bilirubin, can do total bilirubin or indirect bilirubin, and then we get to know. Okay, we normally have a hemogram that give us indication of what we can do as a plan for management. If at all we are going to to bring in what we call uh, phototherapy, or sometimes we just do medication if jaundice is secondary to sepsis, if jaundice is secondary to anemia or any other hemolytical conditions, we also manage sequentially with that. So we have asymmetrical movements, unequal limb movements suggesting fracture nerve injuries. If the baby is trying to raise one hand and the other one is also struggling to be raised, so we don't have that symmetrical movement, then that can be indicating or a show of a nerve injury. Check on the swelling, generalized swelling that can be related to cardiac, renal, lymphatic abnormalities. So we check on the edema, the generalized swelling, call it edema, okay? So let's start with the head examination, the skull. What do we expect in the skull as a normal finding? One, anterior fontanelle should be soft, flat, and diamond shaped. Two, posterior fontanelle small and soft, such a palpable and slightly movable. Head circumference appropriate for gestational age. Mild molding may be present after vaginal delivery, and then the scalp intact without any lesion. If you find any lesion, that's a degree of mechanical injury during the birth. Head circumference appropriate for gestational age. We do measure head circumference using the tape measure. Okay, we get to know. So yeah, so head circumference around 30 something centimeter there will give us indication of a normal head circumference. Okay, So that is that. And then abnormal findings on the skull, bulging fontanelle. When a fontanelle is raised, tense fontanelle suggesting increasing intracranial pressure or meningitis. And then the sunken fontanelle, depressed fontanelle indicate dehydration. Wide suture, the suture line in the skull, okay, may suggest hydrocephalus or increased intracranial pressure. Then you talk about microcephaly, abnormally small heads are covered due to impaired brain growth. And then macrocephaly, enlarged heads are associated with hydrocephalus or congenital anomalies. Then talk about caput succedaneum, diffuse scalp edema crossing such lines due to birth trauma. Talk about cephalohematoma, that's a periosteal hemorrhage confined within the suture lines. Then talk about craniosynostosis, the craniosynostosis, okay? Just a premature close of cranial suture causing abnormal skull shape, okay? Then let's check on what can be there when you're checking on the face and the eyes. When you're looking at the face and the eyes of the baby and confirming, remember this word first before we go. The abnormal finding in the skull, they're very important in probable managing. Like bulging fontanelle can even indicate sepsis. Okay, sunken fontanelle, dehydration. They're very important. Wide suture, hydrocephalus. Microcephaly, small head circle due to impaired brain growth. Okay. Macrocephaly, enlarged head circumference associated with hydrocephalus or congenital anomalies. But you get someone is having a kind of big head, that's macrocephaly. Okay. Then caput, you should distinguish between caput succedaneum and cephalohematoma. Caput succedaneum is a diffuse scalp edema crossing suture line. The difference mostly like the one crosses the suture line due to the birth trauma, that is caput, and the hematoma is subperisternal hemorrhage. Okay, so it's actually not that on the top like caput. It's basically on the top, very very almost the skin. But also hematoma is just next to the bone, hemorrhage within the bone surface. So you realize that it cannot cross the suture line. Okay, just stay on that specific bone, the top of it. So cephalohematoma is just accumulation of blood clots on that place. So craniosynostosis, premature closure of the, the suture lines. And the fontanelle as well. So that is that. Let's check on the face. Normal findings on the face talk about symmetrical facial appearance, high closure with no discharge, pupils equal and reactive to light, red reflex present bilaterally, spontaneous eye movement present, temporary eyelid, edema may be normal after birth. Okay, so symmetrical facial appearance, eyes clear with no discharge, pupils equally and reactive to light, red reflex present bilaterally, spontaneous eye movement present. Those are just English, so you just get to know them directly. Temporary eyelid edema may be normal after birth. Okay, so if you get to see swelling on the eyelid, that can be normal, can be due to just fluid accumulation. So, despite the fact that it can also be pathological, sometimes it's normal. So, what are the abnormal findings? Facial asymmetry. Facial asymmetry, like you can realize the face is not that equal, both side, left and right. One might be a bit slant or falling, lack of control. One may be looking fine, like a smile on one side, okay, a close of eye on one side, okay. So this one may indicate a facial nerve palsy or abnormalities. And absent red reflex may suggest congenital cataract or retinoblastoma. And red reflex, we use light and we flash light on the on the on the eyes. We can see on the pupil the red color. It's supposed to be there. If not, then congenital cataract or retinoblastoma can be indicated. Conjunctival hemorrhage, small hemorrhage from birth trauma, can see on the conjunctiva of the eye. And congenital cataract, lens opacity impairing vision can also be there. Strabismus, that's persistent eye misalignment suggesting neurological or muscular effect. Then talk about purulent eye discharge, possible neonatal conjunctivity or infection. Check on the ears, well formed and symmetrical pinna recoil present. High ear alignment at or above the level of the heights respond to sound stimuli as well. Mm, let's check on the abdominal findings when talk about the ears and eyes. So especially the ears, I've said the normal, well-formed, pinna recoil present. When if you touch it, it can get back to its shape. Highly alignment at or above the level of the eyes. Yeah, the ears are supposed to be either above or the level of the eye. Respond to sound stimuli. Okay. So when there are low set years associated with chromosomal levels such as the Down syndrome, get to be alert. Malformed pinna, congenital hair deformities, then we have preauricular pits or tags. These are minor anomalies sometimes linked with renal abnormalities. Absent auditory response can as well be there, possible hearing impairment. And then nose, no more finding, no symmetrical and centrally placed, no still patient bilateral and no nasal discharge. Newborn breath can follow through the nose. So when you check the nose and you find the baby is breathing well, no nasal discharge, nostril patent and bilateral, and then no symmetrical and centrally placed, then you don't have issue. But if you check and get what you have, choanal atresia, a congenital blockage of posterior nasal passage causing cyanosis, okay? Because there's no breathing. So that's called the choanal atresia. The nasal flaring, signs of respiratory distress, maybe depressed and nasal bridge, may kind of also like the Down syndrome as well. Okay. Check on the mouth. Lips must be pink, palate intact, tongue midline with free movement, strong sucking and rotting reflex, gums intact without lesion. But when you check and you find cleft lip and palate are having a cleft, then that is congenital defect affecting feeding and speech development. When you check macroglossia, macroglossia is just enlarged tongue associated with hypothyroidism or genetic syndrome. Then check on the thrush, white fungal plaques caused by the candida infection. You know what to do on that. Then you check on the micrognathia, small jaw associated with congenital syndromes. Check on the poor sac reflexes, which may indicate prematurity, neurological dysfunction, or illness. So when you check on the neck and the clavicle region, normal findings that the neck should be short but mobile, no masses or webbing, clavicle smooth and intact, symmetrical neck movement, like abnormal findings, get the torticollis, torticollis is what you call the tight sternocleidomastoid muscle causing head tilt. Neck masses may indicate cystic hygroma or congenital cyst. Webbed neck, seen in chromosomal disorders such as the Turner syndrome, and clavicular fracture, birth injury present with the swelling tendons or peptidins. Chest and breast, normal findings, symmetrical chest expansion, respiratory rate, you get 30 to 60 beats per minute. Breath sound clear and equal bilateral, no retraction or grunting. Small symmetrical breast tissue may be present due to maternal hormones. That is always accepted. When you check on the chest, you find somebody is having a breast like. They are just normal because of the mother's hormone, okay? Now, abnormal findings in the chest region, like retractions, that is the inward chest wall movement indicating respiratory distress. Talk about grunting, attempting to maintain alveolar expansion during breathing difficulty. Okay, so they grunt. Then you talk about tachypnea, respiratory rate above 60 breaths per minute, and bradypnea, abnormally slow breathing rate as well. And then asymmetrical chest movement, which is actually possible pneumothorax or diaphragmatic paralysis. And then absent breath sound may indicate pneumothorax or lung collapse. We talk about Poland syndrome. Poland syndrome is absence of chest wall muscle or breast tissue completely. So the other finding we look at is the abdomen. Abdomen should be soft and rounded, no tenderness, no mass. Umbilical cord contains two arteries and one vein. Bowel sound audible, liver edge may be slightly palpable. When talk about abnormal findings, the abdominal distension may indicate bowel obstruction, necrotizing enterocolitis, which is actually very common, or ileus. Scaphoid abdomen, sunken abdomen associated with diaphragmatic hernia. And then you can check on hernias whether we get the umbilical or inguinal protrusions, okay? Check on hepatosplenomegaly and large liver spleen due to infection, hemolysis or metabolic disease as well. Check on omphalitis, infection of the umbilical stump causing redness, swelling, or discharge. Absent bowel sound, possible intestinal obstruction or paralytic ileus as well. So those are very key things. Mm. Omphalitis is very key. You should check on that. Omphalitis is infection of the umbilical stump causing redness and swelling or discharge, called omphalitis. Okay, don't forget that. So my presentation is always 20 minutes. We'll continue from there. We have a halfway of the same presentation to cover. Blessings and have a nice time.